Hypertension is one of the most common conditions seen in clinical practice. But hidden within the millions of patients living with high blood pressure is a form that often goes unnoticed: primary hyperaldosteronism, also known as Conn's syndrome. Conn's syndrome is a hormonal disorder in which the adrenal glands produce too much aldosterone. This excess hormone leads to sodium retention, potassium loss, and persistent hypertension that can be difficult to control. Understanding Conn's syndrome is essential because early diagnosis and proper treatment can dramatically improve blood pressure, correct electrolyte abnormalities, and reduce long-term cardiovascular risk. In this video, we will explore Conn's syndrome step by step: its prevalence, causes, pathogenesis, clinical features, diagnostic approach, treatment options, and prognosis.
Albert, it's high again. Again. I took my medications last night. I didn't miss anything. But look at this.
What is it this time?
168/108. It's like the numbers don't even care that I'm taking the pills.
Emma, that's almost the same as yesterday. And the day before. You've been so strict with your medications. This doesn't make sense.
I don't understand it anymore. My doctor keeps increasing the dose, adding new drugs. But my blood pressure just stays high. And this weakness, my legs feel heavy every morning.
You've been complaining about that for weeks. The cramps, the tiredness. Emma, something else is going on. This isn't just hypertension.
I'm only 38, Albert. Why does my blood pressure behave like I'm 60?
Then we need answers. Real answers. Let's go back to the clinic, not just for another medication. Let's ask why the treatment isn't working.
You're right. I can't keep pretending this is normal. I'll go today.
Good morning, Emma. I've reviewed your home readings. They're consistently high despite multiple medications. Can you tell me more about your symptoms?
I feel tired all the time. My muscles cramp, especially in my legs. Sometimes I get palpitations and headaches. I drink a lot of water lately. I'm always thirsty.
Any swelling in your legs? Any family history of hypertension or kidney disease?
No swelling. My parents have mild hypertension, but mine started early, around 35, and it's been getting worse.
You're on 3 antihypertensive drugs, correct?
Yes. Amlodipine, losartan, and hydrochlorothiazide. None of them seem to help.
That's important. Resistant hypertension at your age, plus muscle weakness and thirst. We need to look deeper. I need to examine you, please.
Okay, doctor.
Your blood pressure today is 170/10, 8 millimeters G. No edema. Heart sounds normal. No signs of Cushing's or thyroid disease. But your pulse feels slightly irregular. We'll check your electrolytes. Emma, I'll order a few tests to understand what is happening. These tests include serum electrolytes, especially potassium and sodium, plasma renin activity, and aldosterone concentration. To calculate the aldosterone-renin ratio, renal function tests to rule out secondary causes, ECG to check for hypokalemia-related changes, CT adrenal scan if the hormonal tests suggest primary hyperaldosteronism.
So you think my hormones might be causing this?
Exactly. Sometimes the adrenal glands produce too much aldosterone. It raises blood pressure and lowers potassium. It's called Conn syndrome, and it's treatable once we confirm it.
Emma's case shows the classic pattern of resistant hypertension with muscle weakness and fatigue. These symptoms raise suspicion for primary hyperaldosteronism, Conn syndrome, a condition where excess aldosterone causes sodium retention, potassium loss, and persistent hypertension. The aldosterone-renin ratio, ARR, is the key screening test. A high aldosterone with suppressed renin suggests autonomous aldosterone production. Confirmatory suppression tests and adrenal imaging help differentiate unilateral adenoma from bilateral hyperplasia. Identifying Conn syndrome early is crucial because, unlike essential hypertension, it's potentially curable.
Emma, thank you for coming in. I have all your results now.
I've been so anxious. Please tell me what you found.
Your blood tests confirm primary hyperaldosteronism. Your aldosterone is very high, and your renin is almost zero.
So this explains why my blood pressure never goes down.
We also did a CT scan to see where the hormone is coming from.
And what did it show?
There's a 1.6 centimeters nodule on your left adrenal gland. It's producing the aldosterone.
Is it cancer?
No, Emma. These nodules are almost always benign, but they cause big problems because of the hormones they release.
In Emma's case, the diagnosis is confirmed by a clear unilateral adrenal adenoma on CT. But in many patients, imaging alone is not enough. When the CT is unclear, normal, or shows abnormalities on both sides, doctors may need a special procedure called adrenal vein sampling. What is adrenal vein sampling, AVS? It is a catheter-based procedure. Blood is taken from each adrenal vein. Measures aldosterone levels from right and left adrenal glands. Helps determine which side is overproducing the hormone. Used when CT findings are unclear or unreliable. When is AVS indicated? Age 40 to 45 years. CT shows bilateral adrenal abnormalities. CT is normal or inconclusive. CT shows unilateral nodule, but patient is older. Suspicion of bilateral hyperplasia. Biochemical tests are discordant. Before surgery, when imaging is not definitive. Interpretation. Lateralization index, LI. LI greater than 4 indicates unilateral aldosterone excess that needs surgery. LI less than 3 indicates bilateral hyperplasia that needs medical therapy. Contralateral suppression. Low aldosterone on the opposite side supports unilateral disease.
Since it's unilateral, the best treatment is laparoscopic removal of the left adrenal gland.
Surgery?
Yes. And the good news is that surgery often cures the hypertension or makes it much easier to control.
So this can actually be fixed.
Absolutely. Before surgery, we'll start spironolactone to stabilize your potassium and blood pressure. You've been struggling for years, Emma. Now we know the cause, and we can treat it.
Thank you, doctor. I finally feel like I can breathe.
Honey, how are you feeling after surgery?
I feel a little sore, but lighter somehow, like something heavy is gone.
It is gone. The doctor said the surgery went perfectly.
Did he tell you the plan? What happens next?
Yes. He said removing the left adrenal gland should fix the hormone problem. Your aldosterone levels will drop, and your blood pressure should start improving soon.
After all these years, it feels unreal.
He also said you'll stay on your medications for a short time while your body adjusts. But the prognosis is very good.
He told me before surgery that because the nodule was only on one side, the cure rate is high.
Exactly. He said many patients see their blood pressure normalize or need much fewer medications.
I just want to live normally, without feeling tired all the time.
You will. He said your potassium will stabilize, your energy will come back, and the headaches should stop.
I'm scared, but hopeful.
Hopeful is good. And you're not alone in this.
Thank you for staying with me through everything.
Always.
Emma's surgery was successful. Because her condition was caused by a unilateral adrenal adenoma, removing the affected gland offers an excellent chance of cure. Over the next weeks, her blood pressure will gradually improve, her potassium will normalize, and her symptoms will fade. This is the expected prognosis for patients with unilateral primary hyperaldosteronism. Primary hyperaldosteronism, also known as Conn's syndrome, is more common than many clinicians realize. It affects about 5 to 10% of all patients with hypertension and up to 20% of those with resistant hypertension. Because potassium levels can be normal, many cases remain undiagnosed. With improved screening using the aldosterone-renin ratio, we're identifying this condition much more frequently. Conn's syndrome has two major causes. The first is a unilateral aldosterone-producing adenoma, often called an APA. The second, and more common cause, is bilateral adrenal hyperplasia. Rarely, familial hyperaldosteronism or adrenal carcinoma may be responsible. Identifying the correct cause is essential because treatment differs significantly. The hallmark of Conn's syndrome is excess aldosterone production. Aldosterone increases sodium retention and potassium loss, leading to hypertension, hypokalemia, and metabolic alkalosis. As aldosterone rises, renin becomes suppressed due to negative feedback. This biochemical pattern is the foundation of diagnosis. Clinically, Conn's syndrome often presents with resistant hypertension. Patients may experience muscle weakness, fatigue, headaches, and increased urination or thirst. During laboratory testing, hypokalemia and metabolic alkalosis are common findings. Elevated aldosterone with suppressed renin strongly supports the diagnosis. Diagnosis begins with the aldosterone-renin ratio, the primary screening tool. If the ratio is elevated, confirmatory tests such as saline suppression, captopril challenge, or fludrocortisone suppression are used. Treatment depends on whether the disease is unilateral or bilateral. For unilateral adenomas, laparoscopic adrenalectomy is the preferred and often curative option. Before surgery, medications like spironolactone or eplerenone help stabilize potassium and blood pressure. Bilateral hyperplasia is managed medically with mineralocorticoid receptor blockers. After treatment, blood pressure and potassium must be monitored closely. The prognosis for Conn's syndrome is excellent when treated appropriately. Patients with unilateral adenomas often experience significant improvement or complete normalization of blood pressure after adrenalectomy. Potassium levels return to normal, and long-term cardiovascular risk decreases. Those with bilateral hyperplasia achieve good control with lifelong medical therapy. Early diagnosis leads to better outcomes and improved quality of life.